Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very, very handy in your line of duty. So I welcome you all to part 106 of our MCQ series, Measuring in Infectious Diseases. Welcome. The first question reads, Mrs. FBK, a 24-year-old female patient, presents to your hospital with a chief complaint of suprapubic pain. She has a fever. Her body temperature is 101.3 degrees Fahrenheit. Your physician on call performs a pelvic exam, and the results include purulent discharge from the cervix, and there is no adnexal tenderness, there is no nausea, neither is there vomiting. And her pregnancy test is done, which turns negative. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mrs. FBK now? Would it be ceftriaxone at a dose of 250 milligrams administered intramuscularly alongside 100 milligrams of doxycycline capsules taken twice daily for 7 days? Or would you opt to administer 750 milligrams of levofloxacin orally once a day for a week? Or would you administer 250 milligrams of ceftriaxone IM stat and 1 gram of azithromycin orally stat? Or would you choose to administer 1 gram of azithromycin orally stat alongside 100 milligrams of doxycycline capsules taken twice daily for 3 weeks? I'll give you 10 seconds to choose the correct answer. Both answers A and C are correct. I would choose to either administer a stat IM dose of ceftriaxone 250 milligrams plus 100 milligrams of doxycycline taken twice daily for a week, or I would administer ceftriaxone 250 milligrams IM stat alongside 1 gram of azithromycin taken orally as a start dose. Remember, FBK has signs and symptoms as well as a physical exam finding consistent with cervicitis, which can be treated with options A or C. Just like to remind you that fluoroquinolones like levofloxacin are no longer recommended due to resistance. It has become a major issue. Now, if the patient had an adnexal tenderness or evidence of involvement of the fallopian tubes or even the ovaries, then the treatment would most likely require an inpatient admission with longer treatment. Just like to remind you that patients with cervicitis will usually have cervical motion, or what we call cervical motion tenderness, abbreviated as CMT, on pelvic exam. Let's move to the next question, please. The next question reads, Mrs. SKL, a 30-year-old female patient, presents to your urology clinic and is diagnosed with pyelonephritis. 10 weeks ago, She received a 3-day course of cotrimoxazole for the treatment of uncomplicated urinary tract infection. She informs the physician she's allergic to penicillins, and the last time she took penicillins, she had a rash. Currently, she takes no other medications, so my question to you is, which of the therapeutic options listed below would be the most appropriate for Mrs. SKL now? Would it be fosfomycin, nitrofurantoin, ciprofloxacin, or cotrimoxazole? I'll give you 10 seconds to choose the correct answer. I would settle for ciprofloxacin. I would like to start by saying that fosfomycin and nitrofurantoin are discouraged in patients who are suspected of having acute pyelonephritis. And cotrimoxazole shouldn't be used again if it has been used within the past 3 months or if the resistance rates in the community are above 20%. You should assume this patient isn't pregnant, since no additional information is provided in that regard. It would be prudent to assess her pregnancy status and or even recent sexual activity prior to giving a fluoroquinolone antibiotic. Let's move to the next question, please. And it reads, Master TXM, a 6-year-old boy, lives in a household whose members develop influenza during a community outbreak. He hasn't received a flu vaccine this year, and the pediatrician recommends prophylaxis for TXM. So my question is, for how long should this prophylaxis last? Should it be for 8 weeks, 2 weeks, 6 weeks, or 4 weeks? I'll give you 10 seconds to choose the correct answer. Ideally, it should last 6 weeks. I would like to start by saying that children require 2 doses of influenza vaccine during a community outbreak like this particular one, and therefore 6 weeks of prophylaxis is needed as per the manufacturer. Remember, 7 to 10 days of prophylaxis is adequate for adults, since they only require 1 dose of the vaccine in order to generate adequate active immunity. That does not apply to the children. Now, prophylaxis includes the use of antivirals such as oseltamivir, marketed as Tamiflu, or even zanamivir, marketed as Relenza, which are both neuraminidase inhibitors that are effective against influenza viruses types A and B. Let's move to the next slide, please. And it reads, most macrolide antibiotics inhibit CYP3A4, and this is responsible for several clinically relevant drug-drug interactions. So my question to you is, which of the macrolides listed below is an exception to this? Is it the erythromycin marketed as Kitek? Is it clarithromycin marketed as Clasid or Biaxin? Or is it azithromycin marketed as Zithromax? Or is it erythromycin marketed as Eritab or Emycin? I'll give you 10 seconds to choose the correct answer. Azithromycin, Zithromax it is. Now, azithromycin lacks clinically relevant drug-drug interactions. All the other three macrolides are CYP3A4 inhibitors. I would like to start by saying that technically azithromycin is an azalide, not a macrolide in the purest sense, due to it having what we call a 15-membrane ring versus a 14-membrane ring, which is the structure of the other three. Now, most clinicians categorize it with the macrolides due to their similarity in structure and even characteristics, as well as mechanism of action and even antibacterial coverage. So it's a broad assumption, but in the real sense, azithromycin is an azalide, not a macrolide. So let's move to the next question, please. And it reads, Mr. PKT, a 67-year-old male patient, presents to your chest clinic with community-acquired pneumonia, CAP. Currently, he takes aspirin, enalapril, and metoprolol alongside gemfibrozil and simvastatin. He has a past medical history of hypertension, hyperlipidemia, and coronary artery disease. So my question to you is, which of the therapeutic options listed below would be the most appropriate for PKT? Would you settle for telithromycin? Would you choose erythromycin and coamoxiclav? Or would you settle for azithromycin and coamoxiclav? Or would you settle for clarithromycin and coamoxiclav? I'll give you 10 seconds to choose the correct answer. I would opt for azithromycin and coamoxiclav augmentin. Now, I would like to start by saying that simvastatin, marketed as Zoco, should not be used or co-administered with erythromycin, clarithromycin, or telithromycin. There is a contraindication there because of obvious reasons. Remember, each of those macrolides is known to inhibit CYP3A4, which produces a marked increase in simvastatin plasma concentrations, and increases the risk of hepatotoxicity and even rhabdomyolysis. Now, azithromycin is generally considered not to be a potent inhibitor of CYP3A4, although a few case reports suggest that interactions due to this mechanism may be possible, though infrequent. So C would be the best answer in this particular question. Let's move to the next question, please. And it reads, Mr. J.O.P., a 57-year-old male patient, presents to your hospital with a chief complaint of low-grade fever and muscle weakness, which has lasted the past 4 months. On examination, a systolic murmur is heard, and the echo shows the following results. There is moderate mitral valve regurgitation, and there is valvular vegetation. Now, the blood cultures grow E. fecalis, and in vitro tests reveal penicillin susceptible, aminoglycoside resistant, and streptomycin resistant enterococci. So my question to you is, which of the therapeutic regimens listed below would be the most appropriate for Mr. J.O.P.'s clinical scenario? Would you choose to treat him with vancomycin and aminoglycosides for 6 weeks? Or would you opt to administer ampicillin and ceftriaxone for 6 weeks? Or would you settle for ampicillin and streptomycin for 4 weeks? Or Would you settle for vancomycin and gentamicin for 6 weeks? I'll give you 10 seconds to choose the correct answer. I would settle for ampicillin and ceftriaxone for 6 weeks. Now, I would like to start by saying that approximately 97% of cases of enterococcal infective endocarditis, abbreviated as IE, are caused by Enterococcus faecalis, and the majority of these cases remain susceptible to beta-lactams and vancomycin, but aminoglycoside resistance is increasing in frequency. Now, patients with 3 or more months duration of symptoms was successfully treated with 6 weeks of therapy in a clinical study that was done. And that explains why B would be the best bet in this particular clinical scenario. Let's move to the next question, please. And it reads, Mr. CWO, a 68-year-old male patient, develops an initial case of Clostridioides difficile associated diarrhea during a hospital admission at your hospital. Some of the pertinent labs include a WBC of 35,000, a serum creatinine of 2.5 milligrams per deciliter. His blood pressure is 90 systolic, 50 diastolic. After fluid resuscitation and vasopressor therapy is initiated. So my question to you is, which of the regimens listed below would be the most appropriate for Mr. CWO's C. difficile infection now? Would you choose to treat him with vancomycin, metronidazole, or vancomycin plus metronidazole, or Fidaxomycin monotherapy? I'll give you 10 seconds to choose the correct answer. I would choose to treat this gentleman with the oral vancomycin and IV metronidazole, alternative C. Now, vancomycin plus metronidazole is appropriate for severe, complicated cases of Clostridioides difficile associated diarrhea, like this particular one. Remember, Mr. CWO's case is classified as complicated due to his hypotension and shock. Now, I would like to add that Fidaxomycin, marketed as Difficid, is also FDA approved for the treatment of diarrhea due to Clostridioides difficile, but the combination of vancomycin and metronidazole is preferred in this particular case because of cost, among other reasons. Now, in patients with severe disease, where the WBC exceeds the 15,000 mark, and where serum creatinine is elevated by more than 50% and or a ZAR score of equal to or more than 2 is being treated in the ICU, the initial treatment for C. difficile infection should include dual therapy, not monotherapy like alternatives D, B, and A. Now, just like to remind you that the ZAR score factors in age over 60 years, a body temperature above 38.3 degrees centigrade, albumin levels below 2.5 grams per liter, a WBC count above 15,000, and endoscopic evidence of pseudomembranous colitis, and even treatment in the ICU. That's just a by the way. Let's move to the next question, please. And it reads, BBB, a teenage high school soccer player, receives confirmation of infectious mononucleosis, IM. She inquires if she will be allowed to play soccer now that she has been diagnosed with IM. Now, bearing in mind the risks of splenic injury and chronic fatigue, make decision making in this scenario a challenge for the clinician caring for members of the athletics team with IM. So my question to you is, why is this so? Is it because splenic disease results in chronic fatigue, or is it because a splenectomy must be performed due to infection, or is it because splenomegaly is a symptom of IM, or is it because chronic fatigue may result in a higher incidence of injury to the spleen? I'll give you 10 seconds to choose the correct answer. C is the correct answer. I'd like to start by saying that splenomegaly in IM occurs as a result of lymphocytic infiltration enlarging the spleen beyond protection from the rib cage. It becomes susceptible to rupture either spontaneously or traumatically. There is no consensus among health professionals that an athlete must be asymptomatic with resolution of symptoms such as fever, fatigue, and pharyngitis before they initiate any return to physical activity. Now, the question of when an athlete can return to play following IM is very complex because of the serious complications of splenic rupture if it does occur because of resumption of contact during physical activity. Now, splenic injury is rare, but it may occur spontaneously or with modest abdominal trauma. And I would like to add that protecting the athlete from splenic rupture should be at the forefront when making a return to play decision. And the nature of progression of splenic enlargement can be unpredictable, so you have to be very, very careful when advising such a sportsman. And I would like to emphasize that IM also carries the risk of persistent or chronic symptoms, most notably fatigue, neurologic, hematologic, cardiac, and even respiratory complications. So be very careful with such youths who are eager to return to their sports activities. Let's move to the next question, please. And it reads, Mrs. RMM, a 45-year-old female patient, is rushed to your accident and emergency department with significant penetrating head trauma during a motor vehicle accident. The trauma required neurosurgical repair. 5 days into her admission, she develops symptoms consistent with meningitis. The clinical team does a lumbar puncture which confirms the diagnosis. Bacterial meningitis is the most likely cause of this condition. So my question to you is, which of the regimens listed below would be the most appropriate for Mrs. RMM now? Would you choose to treat her with levofloxacin and cefepime? Or would you choose to infuse levofloxacin and vancomycin? Or would you settle for cefepime and vancomycin? Or would you choose ampicillin, cefepime, and vancomycin? I'll give you 10 seconds to choose the correct answer. I would settle for C, cefepime, alongside vancomycin. Remember, patients with penetrating head trauma and or neurosurgery are at an increased risk of meningitis due to Staphylococcus aureus or S. epidermidis, and even Pseudomonas aeruginosa. Now, cefepime and vancomycin is the only regimen that provides optimal coverage for these suspected pathogens. The others would fail you miserably. Let's move to the next question, please. And it reads, Mr. KHT, a 57-year-old male patient, presents to your accident and emergency department with signs and symptoms of osteomyelitis. My question to you is, which of the medications listed below would not be suitable for him and would need to be discontinued following this diagnosis? Is it isavuconazonium, marketed as Cresemba? Would it be oritavancin, marketed as Obactiv? Would it be tedizolide, marketed as Civextro? Or would it be Evicas, ceftazidime avibactam? I'll give you 10 seconds to choose the correct answer. So oritavancin or Obactiv it would be. Now oritavancin is a lipoglycopeptide antibacterial drug which is indicated for the treatment of adults with acute bacterial skin and skin structure infections caused by or suspected to be caused by susceptible isolates of designated gram-positive microorganisms. It's usually administered IV by infusion. Now, in phase 3 ABSSSI clinical trials, more cases of osteomyelitis were reported in the oritavancin treated arm than in the vancomycin treated arm. So there is a risk there. I'd like to add that we should monitor patients for signs and symptoms of osteomyelitis. And if osteomyelitis is suspected or diagnosed, we should institute appropriate alternative antibacterial therapy. I would just like to add as a by the way that tedizolide, which is marketed as Civextro, is an oxazolidinone antibacterial agent which is indicated in adults in the treatment of ABSSSI caused by susceptible bacteria. It can be administered orally or IV, and it is not known to cause osteomyelitis. Now, ceftazidime avibactam Evicas is also not known to cause osteomyelitis. So the culprit there would be oritavancin. Let's move to the next slide, please. And it reads, Master JHK, a 6-year-old boy, presents to your pediatric accident and emergency department. He has no known past medical history, and the chief complaint, according to the mother who brings him to the department, is 2 days of worsening sore throat and fever, with no ear pain and no cough. On physical examination, the pediatrician notices bilateral tonsillar exudates with anterior cervical lymphadenopathy. Apparently, he meets most of the center criteria to be treated for his strep pharyngitis. My question to you is, which of the pathogens listed below is most likely the causative microbe? Is it Streptococcus pneumonia, Streptococcus viridans, Streptococcus pyogenes, or Streptococcus bovis? I'll give you 10 seconds to choose the correct answer. Streptococcus pyogenes it would be. Now, group A, beta hemolytic streptococcus. That is, Streptococcus pyogenes is the cause of bacterial pharyngitis when people think of strep throat. Now, while the center criteria isn't perfect, it can serve as a guide in the clinical evaluation and the clinician's management decision. It can be very useful. I'd just like to add as a by the way that this center criteria includes the presence of fever, scores 1 point, the presence of tonsillar swelling and exudates, scores a point, the presence of tender anterior chain cervical adenopathy also scores a point, the absence of a cough scores a point, and a score of 2 or more suggests getting a culture, and if it turns positive, then we should treat with an antibiotic. Now, a modified tool called the MCISAAC utilizes the patient's age, where being less than 15 years of age adds another point, and being over 45 years subtracts a point. It can be used in the A and D scenario or environment to make a clinical decision. Let's move to the next question, please. And the next question reads, Mr. ASA, a 34-year-old male patient, presents to your accident and emergency department with a chief complaint of 7 days of ongoing fever, which fluctuated between 101 and 102 degrees Fahrenheit. 10 days ago, he was treated for bacterial sinusitis at a small clinic using amoxicillin. 3 to 4 days into his treatment with amoxicillin, his sinus symptoms, that is sinus tenderness, pressure filling, and purulent drainage, improved to his baseline. However, he noticed that his oral temperature was 101 degrees Fahrenheit and it remained unchanged. The vital signs include a temperature of 101.3, a pulse of 83, a respiratory rate of 12, blood pressure of 135/88. On physical examination, there is no evidence of rash or shortness of breath or sinus tenderness on palpitation. There is no earache, no red or swollen tympanic membranes, and no lymphadenopathy. And the lung and cardiac exams are normal. His CBC and Chem7 are also normal. So my question to you is, which of the following is the cause of ASA's fever? Is it bacteria, beta-lactamase producing bacteria, drug fever, or a viral infection? I'll give you 10 seconds to choose the correct answer. So drug fever is the correct answer. Now, since ASA is presenting with improved symptoms related to his sinusitis and no other evidence of a new infection, this is most likely a case of drug fever. Now, common causes of drug fever is the exposure to beta-lactam antibiotics. The only way to verify this diagnosis is to stop the antibiotic and see if the fever resolves within 72 hours of stopping amoxicillin. I would just like to emphasize that stopping antibiotics and not switching to another drug class would also be appropriate, since he will soon have received his 10 days worth of antibiotics. If additional antibiotic therapy is warranted, then switch to another class other than the beta-lactams. It is also important to remember that while the CBC was normal and there was no rash present, may not fully, in my opinion, rule out a drug fever, as they are only present in about 25% of cases. The presence of eosinophils and or a rash could be helpful in further establishing the diagnosis, but shouldn't be relied upon as the sole indicator of or for drug fever, in my opinion. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, please remember to give it a thumbs up, to like it, to share it widely with your peers, and if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come, and I thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you in the next video. Thank you.